I'm with the Health Science Center, and the video reporter right there is Mark Johnson, also from the UT system. And I have brought along Dr. Sara Espinoza. She is the Section Chief for Research and Division Geriatrics and Gerontology, Palliative Medicine, and Associate Professor at the UTHSCSA Health Science Center in San Antonio. Dr. Espinoza is also a clinical investigator for the Geriatric Research Education and Clinical Center and a staff physician at the Audie L. Murphy VA Hospital. Dr. Espinoza earned her medical degree from the University of Virginia School of Medicine, and her research focus is on understanding the geriatric syndrome, frailty, an important clinical geriatric syndrome which causes older adults to be at risk for multiple adverse outcomes such as falls, disability, and nursing home placement. So please help me welcome Dr. Sara Espinoza.
Thank you. Okay, so I hope you can hear me. I'll try to talk loud. If you can't hear me, just say, let me know. But I'm really excited to be here with you today, and just to tell you a little bit about what I'm interested in. As Jose mentioned, I am a geriatrician. I'm an internal medicine trained doctor. After medical school, I did a residency in internal medicine, and then after that, I did a fellowship in geriatric medicine. And so I did 3 years of training just taking care of older patients, and I really loved doing that. Right now, although I'm a physician at the Health Science Center, I only see patients at the VA right now, but I have a lot of colleagues at the Health Science Center who see patients outside the VA. But we have a lot of programs for older adults within the VA. We have a clinic, and we also have some nursing home, and we also have a house call program. So I'm involved with those. So today what I want to just give you some brief information about frailty, which is something that I've been interested in for a long time. But we'll go ahead and get started. The first thing I wanted to talk to you about is trends in aging across the United States. As you guys have probably read in the news and know, the country is undergoing a boom in aging individuals. This is statistics from the U.S. Census Bureau, which shows the proportion of individuals over the age of 60 from 1990 projected to the year 2030. And you can see the numbers of people over the age of 60 are growing steadily and are expected to grow to about 90 million people in the year 2030. That's primarily related to the baby boomer population, which is now hitting the 65 and older age mark. My parents are both baby boomers, and my dad is, I think he's 67 now, and my mom is around hitting 65. So that's the main reason, part of the main reason for this boom. But also because we've had good medical care, and we've been able to treat a lot of diseases, primarily like infectious diseases. So, hey, Dr. Long. So that's the main reason why we've seen the growth in the aging population. Oh, Dr. Lum is joining me. Oh, I'm excited. This is Dr. Helen Lum. She is also a geriatrician, and she works at the Health Science Center at the Medical Arts and Research Center building, which is a new clinic building that they have built off of Floyd Pearl, which is, I guess, kind of behind here. I'm really not good with directions, but I think it's kind of behind where we are. But anyway, so Dr. Lum is also someone who is an expert in geriatrics. And this is Jennifer, right? And I'm not remembering your last name. Tadora. And she is a research assistant with my boss, Dr. Lucy. So thanks for coming, guys. I just got started. So not only is the population of people over the age of 60 growing, but so are the population over the age of 85. This is a table which is just showing you that the people in the year 2050, the population over the age of 85 is expected to quadruple. So when we think about how we're going, It's okay. When we think about how we think of our aging process in the future, what do we think about as our ideal aging? Well, ideally, we want to minimize the number of years that we have to deal with a lot of disease, disability, and depending on others. I mean, for the most part, people want to be active and independent for as long as they can be. And that's generally when people think of the ideal aging situation, they think that they want to remain independent for as long as possible. But as we know, as we probably observed in our parents and people that we know, aging is unique for every person. It's a spectrum and it's very individual. No two people, even if they have the same diseases, will age the same way. And there are genetic factors for that, based on your parents and how they've aged and what kind of diseases run in your family. And there's also environmental factors for that, like your lifestyle, how someone, if they exercise, how they eat, whether they get regular medical care, that kind of thing. So, although everybody would like to age in such a way where they are very, very healthy until they pass away, unfortunately, many older adults will have to suffer with disease, being disabled, and generally being what we call frail. So we want to, our goal as geriatricians is to prevent or delay what we can do and do all we can do to enhance the quality of life for everyone as they age. So, okay, so I just have a few slides about the shortage of geriatrician that we have in the United States. Here, let's see, we need a chair for you. Let me put this one over here. I'm not using this one. In the year 2000, older patients made up at least a quarter of all office visits. And now, 12 years after that, I would probably venture to say that that's gone up. In the year 2000, there was one geriatrician for every 4,000 older people in the United States. And that's in contrast to, we have about one pediatrician for every 1,000 children. And the number of geriatricians is going to continue to fall as people who are geriatricians now are retiring or leaving the field. And also, unfortunately, because there are few doctors going into geriatrics after they finish medical school. I'm giving my slides here. Can you see them?
Yeah.
Okay. So why is it that people are not going into geriatrics? Doctors, I mean, young doctors. Well, unfortunately, medical school graduates have a lot of debt. It costs a lot of money to go to medical school. And unfortunately, geriatricians tend to make less money on average than a regular primary care doctor. So because of this, and because geriatricians take care of more complicated patients, unfortunately, there's not a lot of incentive for young doctors to go into geriatrics. But many of us still do because we love it. So I just want to just tell you, just a few things about what I love about geriatrics is, older patients with more medical problems might be more complex, but I find that to be more interesting. And I enjoy meaningful interactions and making a difference in people's lives. And truly, I think, unfortunately, sometimes the older population are underserved, and I kind of appreciate working with the underserved population. So, and this is another reason why I love geriatrics. These are my grandparents, and that's my son right there, but he's older now. He's about 6. He just started kindergarten. But I think watching my grandparents age had a big impact and influence on me. And my grandparents also had variation in how they aged. My grandfather was pretty healthy until he passed away. He really didn't have much disability or needing to rely on others, but he actually had a fair amount of disease. He had pretty bad heart disease and vascular disease. My grandmother, on the other hand, had very early Alzheimer's, and by the age of probably 70, she was not really recognizing me or my mom even. And so she suffered, unfortunately, from Alzheimer's for a good 10 to 15 years before she passed away.
How old was your grandfather?
When he passed away, I would say early 70s.
Young.
Yes. And when he passed away is when we actually started to notice that my grandmother had Alzheimer's, because he was taking care of her and he was kind of compensating for her. And we had no idea how bad that she was. And actually, in fact, at his funeral, she kept asking where he was. She didn't even realize that he'd passed away. And I was about 12 or 13 when that happened. And at that age, you're very impressionable. And that really had an impact on me. She kept saying, well, where's Louis? Where's Louis? And I'm like, oh my gosh, she doesn't even understand. And I didn't understand even what Alzheimer's was. And actually, in my essay for medical school, I wrote that I would want to cure Alzheimer's disease. But I actually don't do any work in Alzheimer's disease. But anyway, it was very impressionable. And my grandfather here is on my dad's side, and he's still alive. He's about 85, and he's kind of cantankerous and mean, but he's very healthy and very independent. And we love him and we accept him. But anyway. So you can see the variation in how people age just in looking at my grandparents. So now I want to talk about frailty, which is an area of interest of mine that I actually became interested in as a resident. When I was a resident, I would go to see a patient in the hospital, and I felt like I could really pretty much tell from my very first meeting with the patient if they were going to do very well or not do very well during the hospital stay. And I came to understand that as something that people think of as frailty. So that's what I do my research in now. So I'm going to try to give you broad brushstrokes on this, but frailty is thought to be a syndrome. And people who are frail are very vulnerable to decline as they age. They don't tolerate stress very well. So if one person who's not frail gets sick, like a cold or pneumonia, they might not feel well for that period of time, but then they bounce back pretty well. But people who are frail, they don't tend to bounce back too well from an illness. They can kind of continue to decline after that. Let me move forward. For years and years, people have had an idea of what frailty is. Some clinicians say, well, I know it when I see it. But nobody had really tried to define how do we actually define frailty. So this researcher, Linda Freed, came up with a model to define frailty in research. And just very briefly, she defined it as weight loss without trying to lose weight, feeling exhausted, low physical activity, that's another term for that, poor muscle strength, and walking slowly. And she used that as a way to define if you were frail or not. And I'm going to just try to sum this up, but basically what she found that if you met those criteria of being frail, your survival was lower than if you were not frail. And not only was your survival lower, but you were more prone to have falls, become disabled, hip fracture, need to go to the hospital for whatever reason, and also need to enter into a long-term care or nursing home facility. Oh, that's everything I just said right there. So that model has been used in research to identify people who are at increased risk for not doing well as they age. A couple big distinctions that I want to point out is frailty is not really the same thing as being disabled, and it's also not the same thing as having a lot of a lot of medical problems. Because we could probably all think of someone who has a lot of medical problems who's not necessarily frail. They continue to do pretty well. And also being disabled typically is defined as not being able to care for yourself or needing help with shopping or needing to use a walker or something to ambulate. But just having that doesn't necessarily mean that you're so vulnerable to decline. But these things do tend to travel together. So if you're frailer, you are more likely to be disabled. So how can we prevent and how do we manage frailty? Well, unfortunately, there's no known prevention for it and there's no known treatment for frailty. Essentially, we have just good medical care. But there's also lifestyle factors that you can modify that can not ensure, but at least help promote that you're going to age better. So we're going to talk about that a little bit. So what can you do to help prevent frailty? Well, there are known risk factors for frailty. So they've had studies where they looked at people who were not frail at the start of the study and who became frail later, and they looked at the kinds of factors that predicted why they would become frail later, or if they became frail later. So some of the risk factors are here. Well, advanced age, so being over the age of 70. Although there's really not much you can do about that. We're all aging every second right now. Body mass index, which is a measure of your weight over your height. If it's too high or too low is a risk factor. So we should try to maintain a normal, healthy body weight. Being a smoker is not a good thing, so if we can, that's why as doctors we try to counsel people to stop smoking. Having fallen is a predictor, so we can try to reduce things that are going to help us like fall, or so we can do fall prevention. So some of the things for fall prevention are taking care of vision impairment if there are any, eliminating things like rugs in the room that people might trip on, etc. Depression is a risk factor, so we want to treat. Yes, you have a question?
Explain again number 2, the second one.
Oh yes, I'm sorry, I skipped that one. Okay, so socioeconomic status is a term used in research to refer to education and income. And unfortunately, low socioeconomic status has been shown to be predictive of frailty. So low education level and low income level. And those probably, we don't know, but it's probably related to possibly to the fact that people with lower education and lower income may not have good access to medical care, and they may not have the same lifestyle as a higher SES population. So, but there's not a lot we can do about low socioeconomic status for particular individuals either, but that's what that means.
Okay, it seems to me that the more educated a person is, they understand more things and therefore can live longer with less illness.
Yes, you're absolutely right. That's what the data shows. So part of it is because they understand more about disease and how to maybe care for themselves, maybe taking medications better, etc. So, but you're right. Yes. And so I was talking about depression as a risk factor. So if depression is an issue, we need to identify it and we need to treat it. And then other comorbid conditions are also known risk factors like heart disease, diabetes, stroke, hip fracture, and arthritis. But typically these diseases are very common as we get older. They're kind of age related. They tend to increase as we age. But the goal should be to make sure that they're very well managed. So if someone has high blood pressure, we need to make sure they're taking their medications to control it so that they don't end up with a heart attack or a stroke. So. So that's the importance of regular medical care. So okay, we talked about risk factors that we can try to get rid of or fix if at all possible. But what else can we do? Well, exercise is very important for healthy aging. And also maintaining a healthy diet so you have a healthy body weight. These things are preventive, meaning they help to promote healthy aging, but it's never too late to start. Even nursing home patients can exercise safely and will have good beneficial effects. So in this study by Fiataroni in 1994, her name is Maria Fiataroni, she implemented an exercise program to nursing home patients. The average age of the patients was 87, so they were older. They were nursing home patients, so you know that they were not really able to care for themselves by themselves. And she randomized them, or she had a group where they did weight training exercise and a group that did nothing. And she found that the people who did the exercise were able to improve their strength, walk faster, and they did not have any negative effects. Nobody got hurt or, injured because of the exercise. So I like to mention that study because I think it's a good example of even at later stages of aging, whether you're in a nursing home or not, it's not too late to exercise, and it can be done safely with your doctor helping you to do that. So what is recommended for older adults as far as exercise, if we want to exercise? Well, first of all, I want to mention that you should definitely, if you're going to embark on any exercise, you need to talk with your doctor about it to make sure it's safe for you. But the American Heart Association and American College of Sports Medicine recommend aerobic activity for 30 minutes, 5 days a week. You're shaking your head. Does that seem like too much for you?
No, well, yeah, we don't have the time. Some of us don't have time.
Yeah. It's I understand that. I also find it challenging. I showed you my picture of my son, and I have also a daughter. So, and I got a husband and a job and all that. So
The whole 9 yards.
the whole 9 yards. And so I agree, it's not always easy, but and I mean, I haven't always done this, only in the last few years. I wake up early before my kids are awake, they're still sleeping, and I exercise for 20 to 40 minutes depending on the day. So I'm not even reading it, I'm doing 20 about 5 days a week. So I try, and I'm not perfect, but I try to get it in there. And when I'm talking to patients about this, because I know that it's not easy to do, I try to talk to them about the beneficial effects of exercise. I mean, not only is it going to promote your bone, your bone health, your muscle strength, but it has other effects like your sleep improves generally, your just general sense of well-being improves, and it's good also for your heart, for your cardiovascular effects. So it's not easy to do, but we should strive for it. So in addition to the aerobic activity, they also recommend strengthening exercises, which would be like using weights. And I saw some people doing the chair aerobics over, and I thought I saw some little weights going on in there, so that's very good. I typically combine the aerobics with the weights. I do these little videos that you can get online, and you do the weights and the aerobic at the same time. So it's embarrassing that I'm telling you guys what I do. But anyway, that's what is recommended. But there's also recommendations for nutrition. So we want to, especially if you have high blood pressure, we want to have a low salt or low sodium diet, low in fats, low cholesterol, and then alcohol in moderation. So they say 1 drink per day for women is okay, and 2 for men is okay. And actually, some studies show that a little bit of alcohol consumption is good for you for aging, yes. So but just not overdoing it. And the other thing I counsel my patients about as far as nutrition is concerned is I know that these are hard to follow too. And I myself, I love to eat, and I like pretty much all kinds of food, and so it's not easy. But what I like to say is if you follow this on most days and once a week you have a splurge day, that's okay. So, but you know, feel free to chime in, Dr. Lum, if that's bad advice. Whoa.
Sorry.
That's okay. That was a sign from God. So what else can we do besides exercise and diet, healthy diet? Well, make sure you're going to see your doctor regularly, because there's certain vaccines that we need to make sure to get, like our flu vaccine every fall. I hope everybody's gotten it here. There's a pneumonia vaccine that you should get every 5 to 10 years. And there's also like tetanus and all of those, but the real important ones are the flu and the pneumonia vaccine. And then depending on your age and your other medical problems, it could even still be appropriate to do some cancer screening. And we just need to follow blood pressure, cholesterol, and sugar levels. And Dr. Musi's not here to talk about this in detail, but diabetes becomes really common as we age too, so we have to keep monitoring for that. And then also checking for osteoporosis. So important to have regular follow-up with your doctor. And we want to take good care of any diseases that are already there. So being overweight and obesity can lead to diabetes, so we have to control these things as much as we can. We know high blood pressure and high cholesterol can lead to heart disease. Oh, I don't have stroke there, but stroke also. And osteoporosis can lead to bone fractures. So by controlling these things here, we're hopefully preventing the diseases and bad outcomes later. So when should you see a geriatrician instead of a primary care doctor? Well, unfortunately, as I mentioned before, really is a shortage of geriatricians, and not every older adult probably needs to see a geriatrician. But typically, it's recommended that if you have several medications, many chronic diseases, you have multiple specialists involved, so you're seeing like 10 doctors, and you're kind of declining, becoming disabled, having maybe some decline in memory. If you can, get in touch and get a hold and see a geriatrician, it's probably a good idea if it's available to you. Just because a geriatrician is an expert in taking care of multiple chronic diseases and helping to sort of help that patient decide what's best for them. Because, not saying this in a bad way, but each specialist will have their idea about how to take care of this problem. But no specialist is looking at the whole patient and determining how all these problems interact with each other and how the medicines or treatments might interfere with that person's functioning and quality of life. A geriatrician or a very well-trained internal medicine doctor or family physician will be able to kind of put all those pieces together and talk to the patient about what they want and sort of help tailor the treatment to what the patient wants. So in those cases, I think it's good to have a geriatrician on board. Oh, well, maybe we can give these out later, but these are just some websites that have information on healthy aging. If you go to the National Institute on Aging, they have a whole website on exercise, and they even have a handbook that you can download. And actually, I think if you email or write to them, they'll send it to you for free. And there's also some free information on nutritional guidelines. Anyway, that is all I had. I'm happy to answer any questions that you have. Thanks for listening. Does anybody have any questions?
Yeah, the salsa still has people to come in for
Not anymore. Were you a salsa patient?
many years, 20 years.
Oh my gosh. Well, it's really a pleasure to meet you because I actually work with Dr. Kazuda. Have you ever, I don't know if you
No,
met her.
Michael, somebody was.
Yeah, and Martha.
Martha was there.
Yes. Well, you and other people information who were in that study actually was really, we studied frailty in the SALSA study, and so thank you for doing, volunteering your time. But no, we're not doing that anymore. It's kind of, the study is closed, but it was a very good study. So I'll tell Dr. Kazuda you said hi. What's her name?
I knew Martha.
Martha, yeah, she actually retired.
Did she?
Yeah, not that long ago, about a year ago. Yeah.
I did that for over 20 years.
Yes. Any other questions?
Yes, I have a
Yes.
question.
Yes.
Food is a very important part of all of our lives. We all tend to eat too much, in my opinion, here. We eat too much here. And how can we create some interest in management's knowledge of what they can do and our knowledge of what we want? Do we want that much food? Do they have to prepare that much? What are the economics of all this?
Wow.
And we
That's a
need,
good
we
question.
need some, well, my last question is, my feeling is we need some help. Management needs some help. I think what they serve is fine, tastes good, but I can't tell you how much salt goes in the diet. Can't tell you sugar, or the other things that we might want to control individually. How do we get management wrapped into this problem of diet?
Well, thank you. I don't know if there's a committee that you could be involved in.
Well, I'm just saying,
I know.
can we, are they interested, should we?
Well, I think definitely you should be interested especially if you have high blood pressure or diabetes, on the salt and sugar content of the food. And I would think that if you asked management, they could give you some information about that.
No,
No?
we used to
Sorry.
have last week.
Sure.
I was going to talk almost on the same subject that he is.
Okay.
We've asked many times for a nutritionist, someone who can tell us what are we eating. Forget the quantity for a minute. What are we eating? What kind of fat are they giving us? I don't know. I know what I used in my home. We all know what we used in our homes. I don't know what kind of salt or sugar or the contents of the food that they're serving us. There are times when we just try to decipher what is in this dish, and we don't even know. And there's no way of finding out.
Excuse me,
Well, I don't
the
think-
residents, there is a meeting with the chef once a month.
Doesn't mean a thing, Nora.
No.
Doesn't
If you
mean a
put
thing.
it in writing,
That subject has never come up.
yeah,
They shouldn't bring these questions to you. This is a different thing.
Yeah.
We should
I
have
don't
to
mind,
get-
I don't mind. No, but I think,
it's very important,
Yes.
excuse me, it is very important, and I see where they're coming from. The thing is, we have to see that this is, it's not to go to another, but what it is this is an independent living community. They are very blessed to have a chef. But when you are in an assisted living, you have a dietitian in an assisted living. This is a retirement independent living community. But yes, in a nutritionist or a dietitian will say, Miss Alvarez is diabetic, whatever the diet is, and so at the kitchen or when the meals are being prepared, this is what Miss Alvarez is going to get. Here in the chefs will prepare the meal, but there is sugar-free. I'm not aware that there is low sodium, maybe there is. But again, this is where the independent living is coming from and not the, and so again, it's something that I think that your voice should be heard, and I would think that I would write to corporate and say, you know what about if we've if it never has been done, why not now that the company, that corporate hire a dietitian where they can deal with what the residents we have now to their diets to specify,
Well, it sounds like if they could have more information so they can make the choices. Like, I think that's what you're saying. Because like you said, when we cook in our home, we know what we're buying, we know what we're making. And so maybe it sounds like they just want more information so they can make the decisions.
And that's where they have that residents, that's where you have the opportunity when you meet with a chef, and if it's not going anywhere, do you have an address for corporate, for the district manager? He comes in pretty often. I see him here. He's in the dining room when he comes. Write a note and say, you know what, I'm very concerned about my diet. I am really concerned. But actually, you have to write. It's like us writing to our congressman. It's like us writing to the House of Representatives.
We never know when he's here.
Well,
We
but
never know.
But if we address it to that one person, and make sure there is mail that goes out to corporate, that it would get to that one person. But there is also, remember, you meet with the managers, you have a meeting with the managers as well. So you take it to the dietitian, to the chef, and then if the chef doesn't do anything about it, then you take it to the manager, the co-managers, and then the district, or,
It's up the ladder.
yeah, we have to, you can't give up. It's about, I care about myself. I care what I'm eating. What's my intake in sodium, sugar, carbs, or whatever it is that I'm concerned about.
Anybody else have a question? Yes.
When I first came here, the vegetables were just overcooked, fresh vegetables, broccoli and all of that. I just couldn't eat them. So every time we'd have a meeting with a chef, then I'd bring it up, vegetables are still overcooked. Yes. And so what I do now, I do not add salt to my food. If it tasted salty to me, I do not eat it, And then I order a half a order of that particular food.
Yeah, that's one thing I forgot to mention when you were talking about amount of food.
Yes.
If you feel like you're being served too much, you could either ask for less, or you can save half of it for later or another day. So that's something that some people actually recommend to do when you go to a restaurant, to just immediately put half of it in a box to take home, because as you know, the restaurants serve you so much food.
Mm-hmm. But I just couldn't eat their vegetables.
Yes.
Oh, that was-
I think an awful lot of it is self-control too.
Right. Yes.
And then to remember, yes, there's a lot of us that have the same problem, but yet we're not here by ourselves. They have to serve all of us.
Right. I
It's
agree.
a rough
Yes. Yeah. Right. And that's why I mentioned, with self-control, it's not easy to, every day make the best choices. We just went through Halloween, and I confess I ate way too much Halloween candy from my kids' bag. I think Mommy ate most of it, actually. And but I say, oh, I had a bad day. I had 3 pieces of chocolate. Well, tomorrow I'm going to be better, and don't beat yourself up about it if you, had a bad day one day. Just always, there's another day tomorrow, and I'm not going to have so much tomorrow. But chocolate is my favorite, so I have a weakness for that.
But you can have the dark chocolate.
Okay, dark chocolate. Yeah. Any other questions? Well, I really thank you for your attention, and I appreciated meeting all of you.
Thanks.
Thank you. No problem.